Welcome to the latest podcast where experts in rheumatology discuss dose-response differences in treating patients with moderate to severe RA. And now here is our host, Dr. Alvin Wells.
First of all, it's an honor and a privilege to be here for the discussions with not only some of my colleagues, but also what I consider some of my true friends, Dr. Oren Traum, Dr. Grace Wright, and Dr. Aaron Broadwell. We indeed have some of the experts from around the U.S. As you think about treating patients with moderate to severely active rheumatoid arthritis, we have a lot of treatment options. And what our goal of the podcast is give you some evidence-based medicine to come up with appropriate treatment for your patients who have rheumatoid arthritis. Today, we're going to discuss treatment options with Actemra, tocilizumab, as many of you know, and we'll talk about the data that providers might be less aware of as they were in regards to the different treatment options. We have IV, we have subcutaneous, and we're going to talk about what that does in regards to our treatment, the efficacy, safety, and adherence for our patient population. Before we begin the discussion, I want to remind the audience of a disclaimer, the indication and box warning information. This video and podcast are presented on behalf of Genentech, and the information presented is consistent with FDA guidelines. We have been compensated by Genentech to serve as speakers for this program. This video is intended to provide education on Actemra and is not medical advice for any particular patient. All materials are the property of Genentech and may not be recorded, photographed, copied, or reproduced. Actemra is indicated for the treatment of adult patients with moderate to severely active rheumatoid arthritis who have had an inadequate response to one or more disease-modifying anti-rheumatic drugs. Important safety information. Risk of serious infections. Patients treated with Actemra are at increased risk for developing serious infections that may lead to hospitalization or death, including tuberculosis, bacterial, invasive fungal, viral, or other opportunistic infections. If a serious infection develops, interrupt Actemra until the infection is controlled. Reported infections include active tuberculosis, which may present with pulmonary or extrapulmonary disease. Patients should be tested for latent tuberculosis before Actemra use and during therapy. Treatment for latent infection should be initiated prior to Actemra use. Invasive fungal infections, including candidiasis, aspergillosis, and pneumocystis. Patients with invasive fungal infections may present with disseminated rather than localized disease. Bacterial, viral, and other infections due to opportunistic pathogens. The risk and benefits of treatment with Actemra should be carefully considered prior to initiating therapy in patients with chronic or recurrent infection. Patients should be closely monitored for the development of signs and symptoms of infection during and after treatment with Actemra, including the possible development of tuberculosis in patients who have tested negative for latent tuberculosis infection prior to initiating therapy. Actemra is contraindicated in patients with known hypersensitivity to Actemra. Other warnings and precautions include serious infections, gastrointestinal perforation, hepatotoxicity, laboratory monitoring, hypersensitivity reactions, and live vaccines. We will be discussing the safety information throughout this video, but please note that the full warnings and precautions and all other important safety information, including box warnings, can be found in the Actemra prescribing information. So let's get started. You know, as we talked about before, patients with rheumatoid arthritis have a lot of treatment options. And if you look at the ACR guidelines and the EULAR guidelines, they're patient-centric. They say, let's put the patient up front. So Dr. Wright, when you think about that, talk about the goals. How do you address that with your patients, in particular when you think about treating them with Actemra?
Well, it's so great to be here, Alvin. And as you mentioned this, my goal for my patients is to get them to remission. Patients in general want to feel better, and I want them to feel well. I want to get their disease as low as possible and have that fully controlled. And so low disease activity is one such target, but remission for me is a much more stringent target that gets me the benefits of what I want for my patients. And I know when we look at our clinical trials, we'll see ACR responder indices, we'll see a variety of measures. And what I really point patients to are all of the benefits of controlling the totality of their disease by striving for remission.
I like that point, and that's what I talk about my patients as well, trying to get them as best as they can be, right? I like how you talk about wellness. We talk about that for a physician, but sometimes we forget that with our patients. One of the things I tell my patients, time is joints. The more you have tender and swollen joints, the longer that persists. I'm going to, think about, hey, what damage am I doing? Remembering in RADIATE trial, the primary endpoint was the proportion of patients who achieved an ACR20 response at week 24. That's looking at, remember, the ACR components, the tender joints, the swollen joints, the patient pain, the patient global, and it also assesses an inflammatory parameter as well. When you look at the data on Actemra, that 8 milligram per kilogram dose, the 4 milligram per kilogram dose compared to placebo, those ACR responses were 50%, 30%, and 10% respectively. There were also some secondary endpoints we talk about, the ACR 50s, ACR 70, and a DAS28 scores. We're going to come back to those and talk about how we use those in our clinic and put those in perspective. The difference in the DAS28 scores of the three arms were 30.1%, 7.6%, and 1.6% respectively. Actemra 4 milligrams per kilogram plus methotrexate results for ACR 50, ACR 70, and DAS28 are descriptive only, and no formal conclusions can be drawn. Dr. Traum, I know you use these measures in the clinic, so talk a little bit not only about the ACR scores, but how do you approach your patients if you put them on Actemra? I know we got IV, we got sub-Q. How do you help your patients decide?
Alvin, I also am thrilled to be here with you and our colleagues, but to answer your question specifically, I want to get patients into remission, as Dr. Wright said, as quickly as possible. I start with, if I'm using intravenous, 4 milligrams per kilogram. I look for my patient's clinical response soon after starting therapy. If I don't see that, or a substantial reduction in disease activity on 4 milligrams per kilogram IV, or with the every other week sub-Q dosing, then I would increase the IV dose to 8 milligrams per kilogram for the next dose, or modify their sub-Q dosing to weekly. To be the fact that the quicker you can get people into remission, or at least low disease activity, the better they will do in the long run. Damage happens early. You don't want people to kind of smolder and have ongoing inflammation.
I always like to talk about, say, what would I do if I was on the other side of the exam table? So, Dr. Traum, if you were that patient, how do you decide, hey, do I go IV or sub-Q? Does it depend on the patient's lifestyle? Are they traveling all over the world like you and Dr. Wright do all the time? So how would you put that in perspective?
Let's just make this clear, Dr. Wells. I think you're amongst you, Dr. Broadwell, all of us. It really is a patient preference. And then, of course, it's what is paid for by their insurance. That may sometimes have a lot to do with it. But I bring this up as, we're all talking about how patients and physicians or providers should really have a shared decision-making process. And that's what it comes down to.
I think, and hold that thought, because we're going to come back to reimbursement and what we talked to our patients about and what are some of the programs that we put in place with Genentech. Dr. Broadwell, let me get you into the mix here. You look at the data here from the Radiate trial. We see to look at that onset of action within 2 weeks. We look at the ACR 50 response and some of the other secondary endpoints. Are these data points compelling to you, and how do you translate that to your patients?
Absolutely. And again, thanks for having me on. And I look at this study, at the Radiate study. Remember, this is a TNF-IR study. And many, but clearly not all of our patients on Actemra IV are TNF-IR. And so I find that it's very applicable. While you can see those ACR scores and you can see those differences that were noted earlier, as we then shift from that kind of primary response criteria just into true low disease activity, or really remission is what we're looking at here in the DAS28, that's where we start to see some of that peeling away. And that's where we see that 8 milligram per kilogram. So similarly to Dr. Traum, we're going to start at 4 milligrams per kilogram. I think that's a very reasonable thing to do. And we're going to reassess very frequently with many of our patients, assuming their disease control needs it, moving up to 8 milligrams per kilogram. And again, I think that's coming back to, we want that tighter control. We like that remission. And that's where the data comes from the Radiate trial. Dr. Wells, how do you then translate that into the sub-Q? I mean, do you see similar things there?
Yes, and one of the things we do, for example, I like what Dr. Wright said. I sit down with the patient and say, hey, this is what your goal is going to be. It's going to be getting you as close as it can to do the activities and do the things you want to do. And we start off. Like all of you, based on the Radiate data, I started at 4 milligrams per kilogram, and then very rapid. If they're not close to where they and I have agreed they want to be, we're moving that dose up. Not only for the IV, going from 4 milligrams to 8 milligrams per kilogram, but also for sub-Q. You got the dose where you can do it twice a month, or you can go every week, and I think that's really, really telling as well. Dr. Wright, what about you? If you think about this, what do you think about when you talk about the IV versus sub-Q? What are some pearls, and how do you translate that for your patients?
Yeah, again, a lot of this comes to either the payer preference or the patient preference. And for some patients, I've had them say, look, I don't trust myself to stay on target and do this all the time. And I like coming in and talking to other people, being in a space where there are others who are like me, where I feel accepted.
When we talk about the efficacy, of course, we have to balance that with safety. I'm going to highlight some of that. When you look at the data on Actemra, we see the most common adverse reactions that were the incidence of at least 5% were upper respiratory tract infection, nasopharyngitis, headache, hypertension, increased ALT, and injection site reactions. In the RADIATE trial, the difference in serious infections for the 8 milligram per kilogram dose, the 4 milligram per kilogram dose, and the placebo arms were 4.6%, 1.8%, and 3.1% respectively. Even though they were numerically different, the three arms were similar to or comparable in terms of safety results. Can we spend a minute here talking about safety? Because it's always a balancing act. I love it when my patients say, "Hey, I hear some of these side effects and they sound worse than my disease." So, Dr. Traum, what do you do? How do you kind of, I won't say dummy it down, but how do you translate the safety into real world experience for your patients? And when you talk about the IV versus sub-Q, what do you tell your patients, and what do you tell some of your colleagues as you're around the water cooler?
Dr. Wells, I agree that looks like there's a difference here, but I think we all do clinical trials, part of this panel, and we all know that infections, and in particular upper respiratory tract infections, are the most common. The things I really look at are the serious adverse events, serious infections, things that get people hospitalized, need IV antibiotics, death. I mean, those are serious. And then the significant benefit of going from the 4 mg per kg up to the 8, or from the every 2 weeks to weekly. I think it's telling that you really want to get patients to their disease being under great control. Most of our patients come in and say, please don't talk about biologics. Have you read about the side effects?
Right.
Yes, we've read about the side effects. We have to discuss that when we talk about clinical trials. But the reality is, unless I have a particularly ill patient with many comorbidities where I might spend a little bit more time, I said, gee, I think the activity of the disease is actually contributing to some of your comorbidities. You have to take that into consideration, and it really is a balancing act. When they understand that best, then they are more prone to getting into the appropriate therapy, and I try to encourage them to do that.
And I agree with you, Dr. Traum, and that's indeed what we're paying them for. They're paying for our best medical advice, but it is that balancing act. I like how you talked about that. We talked about setting goals for that patient. We talked about some safety. At the end of the day, none of this matters if I can't get the drug for my patients, right? So, Dr. Broadwell, let's talk a little bit about access and reimbursements. Have you had any issues there, or what kind of pearls can we use to help our colleagues when they think about getting Actemra 8 milligrams per kilogram?
Yeah, so I'm heavily active in access throughout the U.S., looking at multiple different drugs and with different organizations. And so I do pride myself on making sure that I am the best trained to make sure that whatever type of access I can try and get. What I found, especially with having both formulations, is that oftentimes you may have some access with one where you don't with another. We know pharmacy benefit managers oftentimes change what we want to do, things like that. And then further, I haven't had locally as much pushback with more advanced dosing, either that being weekly, sub-Q, or with the 8 milligrams per kilogram. Clearly, there are differences with different payers in different regions, so I want to respect that.
That's a good point. So, Grace, you're in New York, and with the patient that you're seeing, are there any major issues, or what kind of pearls could you share with some of our colleagues who might see this presentation?
I really have not had pushback going from 4 mg to 8 mg per kilogram or the sub-Q dose. But again, it's New York City. It's a particular payer distribution that we have here. And that's not the same, let's say, across the banks of the river on the west coast of Manhattan. So again, very variable.
And I think that's why it's important to hear the experience from around the country. Dr. Traum, what about you in California with any of the payers, any major issues there?
We were, at least at one time, one of the most highly penetrated managed care area of the country. I still think we're at least high to the top. We also have incorporated them now with the Providence Healthcare System, folks that, help us with our prior authorizations and just take it from our clinic records as to why we think it's important. I have not had pushback, and I think it's been made readily available to us. So if it's either weekly sub-Q dosing, if it's the 8 milligrams per kg as opposed to the 4, If we're willing to say at least something, which means it's reflected in our notes, then it can happen.
And I totally agree with all of you. And my practice is very similar. One of the things we've also done is partner with specialty pharmacies in our area. So they do the heavy lifting. They write the prioritizations. They do all those forms, and they indeed help to get those things covered, because my job is to help treat these patients and do like all of you do at the end of the day. So I think the take-home message here for our audience is that with Actemra, you have a different dosage. You have the 4 milligrams per kilogram, you have the 8 milligrams per kilogram, and you also have that sub-Q. One is not going to fit for all patients, but that's a luxury of being a rheumatologist. We won't be replaced by AI because it's that art. And so which one's going to be good for the others? We've shown you the efficacy, we've seen some safety, and then reimbursement in our hands is not that big of an issue. Thank you for listening to our expert discussion. Please keep listening to this podcast to hear the RADIATE trial study design and full important safety information. RADIATE is a phase 3 randomized, double-blind, placebo-controlled, 24-week study in rheumatoid arthritis patients who failed at least one tumor necrosis factor antagonist. 170 patients received 8 milligrams per kilogram IV Actemra. 161 patients received 4 milligrams per kilogram IV Actemra. And 158 patients received placebo every 4 weeks while continuing background methotrexate. No other disease-modifying anti-rheumatic drugs were allowed.
Important safety information continued. Actemra is contraindicated in patients with known hypersensitivity to Actemra. Warnings and precautions. Gastrointestinal perforations. Events of gastrointestinal GI perforation have been reported in clinical trials primarily as complications of diverticulitis in RA patients. Use Actemra with caution in patients who may be at increased risk for GI perforation. Promptly evaluate patients presenting with new onset abdominal symptoms for early identification of GI perforation. Hepatotoxicity. Serious cases of hepatic injury have been observed in patients taking intravenous or subcutaneous Actemra. Some of these cases have resulted in liver transplant or death. Time to onset for cases ranged from months to years after treatment initiation. Most cases presented with marked elevations of transaminases greater than 5 times ULN, and some cases presented with signs or symptoms of liver dysfunction and only mildly elevated transaminases. Treatment with Actemra was associated with a higher incidence of transaminase elevations. Increased frequency and magnitude of these elevations were observed when Actemra was used in combination with potentially hepatotoxic drugs, for example, methotrexate. It is not recommended to initiate Actemra treatment in patients with elevated transaminases, ALT or AST, greater than 1.5 times ULN. In patients who develop elevated ALT or AST greater than 5 times ULN, discontinue Actemra. Measure liver tests promptly in patients who report symptoms that may indicate liver injury. If the patient is found to have abnormal liver tests, Actemra treatment should be interrupted. Actemra should only be restarted in patients with another explanation for the liver test abnormalities after normalization of the liver tests. Laboratory parameters. Laboratory monitoring is recommended due to potential consequences of treatment-related laboratory abnormalities in neutrophils, platelets, lipids, and liver function tests. Dosage modifications may be required. Neutropenia. Treatment with Actemra was associated with a higher incidence of neutropenia. It is not recommended to initiate Actemra treatment in patients with a low neutrophil count, for example, absolute neutrophil count ANC, less than 2,000 per cubic millimeter. In patients who develop an ANC less than 500 per cubic millimeter, treatment is not recommended. Thrombocytopenia. Treatment with Actemra was associated with a reduction in platelet counts. It is not recommended to initiate Actemra in patients with a platelet count below 100,000 per cubic millimeter. In patients who develop a platelet count less than 50,000 per cubic millimeter, treatment is not recommended. Elevated liver enzymes. It is not recommended to initiate Actemra treatment in patients with elevated transaminases, ALT or AST, greater than 1.5 times ULN. In patients who develop elevated ALT or AST greater than 5 times ULN, treatment is not recommended. Lipid abnormalities. Treatment with Actemra was associated with increases in lipid parameters, such as total cholesterol, triglycerides, LDL cholesterols, and/or HDL cholesterol. Immunosuppression. The impact of treatment with Actemra on the development of malignancies is not known, but malignancies were observed in clinical studies with Actemra. Actemra is an immunosuppressant, and treatment with immunosuppressants may result in an increased risk of malignancies. Hypersensitivity reactions. Hypersensitivity reactions, including anaphylaxis, have been reported in association with Actemra, and anaphylactic events with a fatal outcome have been reported with intravenous infusion of Actemra. Actemra for intravenous use should only be infused by a healthcare professional with appropriate medical support to manage anaphylaxis. For Actemra subcutaneous injection, advise patients to seek immediate medical attention if they experience any symptoms of a hypersensitivity reaction. If anaphylaxis or other hypersensitivity reaction occurs, stop administration of Actemra immediately and discontinue Actemra permanently. Do not administer Actemra to patients with known hypersensitivity to Actemra. Anaphylaxis and other hypersensitivity reactions that required treatment discontinuation were reported in 0.1%, 3 out of 2,044, of patients in the 6-month controlled trials of intravenous Actemra, 0.2%, 8 out of 4,009, of patients in the intravenous all-exposure RA population, 0.7%, 8 out of 1,068, in the subcutaneous 6-month controlled RA trials, and in 0.7%, 10 out of 1,465, of patients in the subcutaneous all-exposure population. Demyelinating disorders. The impact of treatment with Actemra on demyelinating disorders is not known, but multiple sclerosis and chronic inflammatory demyelinating polyneuropathy were reported rarely in clinical studies. Monitor patients for signs and symptoms potentially indicative of demyelinating disorders. Prescribers should exercise caution in considering the use of Actemra in patients with pre-existing or recent onset demyelinating disorders, active hepatic disease, and hepatic impairment. Treatment with Actemra is not recommended in patients with active hepatic disease or hepatic impairment. Vaccinations. Avoid use of live vaccines concurrently with Actemra. No data are available on the secondary transmission of infection from persons receiving live vaccines to patients receiving Actemra, or on the effectiveness of vaccination in patients receiving Actemra. Patients should be brought up to date on all recommended vaccinations prior to initiation of Actemra therapy. Adverse reactions. Rheumatoid arthritis, RA. The most common serious infections. The most common serious infections included pneumonia, urinary tract infection, cellulitis, herpes zoster, gastroenteritis, diverticulitis, sepsis, and bacterial arthritis. In the Actemra IV monotherapy clinical study, the rate of serious infections was 3.6 per 100 patient years in the Actemra group and 1.5 per 100 patient years in the methotrexate group. The rate of serious infections in the 4 mg per kilogram and 8 mg per kilogram Actemra plus DMARD groups was 4.4 and 5.3 events per 100 patient years, respectively, compared to 3.9 events per 100 patient years in the placebo plus DMARD group. In the 5 phase 3 clinical trials, the most common adverse reactions greater than or equal to 5% of patients treated with Actemra IV through 6 months were URTI, nasopharyngitis, headache, hypertension, and increased ALT. The safety observed for Actemra administered subcutaneously was consistent with a known safety profile of intravenous Actemra, with the exception of injection site reactions, which were more common with Actemra subcutaneous compared with placebo subcutaneous injections IV arm. In the 6-month control period in SCI, the frequency of injection site reactions was 10.1%, 64 out of 631, and 2.4%, 15 out of 631, for the weekly Actemra SC and placebo SC IV arm group, respectively. In SC2, the frequency of injection site reactions was 7.1%, 31 out of 437, and 4.1%, 9 out of 218, for the every other week Actemra SC and placebo SC groups, respectively. These injection site reactions were mild to moderate in severity. The majority resolved without any treatment, and none necessitated drug discontinuation. Drug interactions. Cytochrome P450s in the liver are downregulated by infection and inflammation stimuli, including cytokines such as IL-6. Inhibition of IL-6, signaling in RA patients treated with Actemra, may restore CYP450 activities to higher levels than those in the absence of Actemra, leading to increased metabolism of drugs that are CYP450 substrates. Exercise caution when co-administering Actemra with CYP3A4 substrate drugs where decrease in effectiveness is undesirable. For example, oral contraceptives, lovastatin, atorvastatin, etc. Use in pregnancy. There is a pregnancy exposure registry that monitors pregnancy outcomes in women exposed to Actemra during pregnancy. Physicians are encouraged to register patients, and pregnant women are encouraged to register themselves by calling 1-877-311-8972. The limited available data with Actemra in pregnant women are not sufficient to determine whether there is a drug-associated risk for major birth defects and miscarriage. You may report side effects to the FDA at 800 FDA at 1088 or www.fda.gov/medwatch. You may also report side effects to Genentech at 888883525555. Please see additional important safety information in full prescribing information, including boxed warning,